issues of safety, issues of documentation of clinical effectiveness, cost and economic evaluation, ethical analysis, organizational aspects, social aspects, and legal aspects. The full model is comprising all 9 of them. What we see is that due to the pressure often to be rapid in the production of HTA, there is a tendency to concentrate on the first 4. That is okay. The model allows you to work in a modular way, so you can also apply the model for a rapid scope. The information sharing model is based on so-called core elements, which are basically questions and answers within a framework defined by the HTA core model. The full model comprises about 150 questions. Obviously, in this specific case, some of the questions, or maybe many of the questions, are not really relevant. There may be no specific legal or, for example, ethical aspects. But in some situations, there may be important organizational aspects that are then addressed with a number of questions under the headline of organization. And the idea is that we will have a common repository of questions and answers in so-called cards, which is an electronic thing that you can search in the pool of structured information. You can use it for local reporting, or you can use it for common work where you define the content of core HTA that you do together, still assuming that you need to have a local sort of translation into a specific local reporting. This is now an electronic instrument called the HTA Core Model Online that is in its 2nd version now. So it's moved beyond being a prototype to be something that is actually available for actual work. And this is going to be a big challenge to see how and if the partner organizations are able to take this increasingly into use. It will ask for some flexibility from the partners in the early phases of their production of HTA. Before the reporting, the phase where you're actually collecting the information and assessing the information. There's another challenge with this, which is the fact that several countries primarily base their activities on submissions, so that on the guidelines, sponsors of technologies are asked to make a submission of a file, of a dossier, that is then the basis for the assessment. So a challenge here is going to see how and if it will be possible also to work with the sponsors of the technologies on applying this HTA core model. It may even give efficiency gains at the level of the companies. The last thing I'll address is stakeholder involvement. It's important that we have this stakeholder involvement, and from initial sort of explorations during the first project from 6 to 8, we, from that point, we've actually, with the joint action, moved quite fast with a much more committed involvement of stakeholders in UNETA in a stakeholder forum, which is part of the organization and management structure of UNETA. And in 2 groups, we have actually less than the 4 seats that we defined for each group. That is the payers and the providers. While, for example, industry has actually shown a big interest in participating in the stakeholder forum. We also defined for 3 work packages so-called stakeholder advisory groups that have been working closely with the researchers in the development of the methodologies in relation to HTA core model and also relative effectiveness assessment and new technologies. Currently, we have a call out for declaration of interest to go into the stakeholder forum of the Joint Action 2. That call is during the whole month of October. Thank you very much for your attention.
Sorry, it's me again. Thank you, Finn. I'm going to give you some insight in some of the work that is currently ongoing, that has been ongoing for several years, and that will continue for the next 3 years, on some of topics and some of the actions. So the first one of the rapid HTA, the core production of core information for rapid HTA. One on the question of the development of methodology for assessment of technologies, and then how to improve the evidence generation. So the first question, I left you with the processes in France. So how will European cooperation help national HTA processes? I can describe the process in France as it is. We start from, if I take the example of a rapid HTA, where a new drug or a new device is submitted for HTA and to advise on its inclusion on the healthcare basket. So a dossier is submitted by a pharmaceutical or devices company. It's then the internal assessors that have to work. And remember the distinction made yesterday by Mike Drummond on the assessment part and the appraisal part. Assessment is how we gather all the and summarize all the available information we need to make our judgment. And the appraisal part is more the final part where you issue the guidance, and then we have a conclusion with it's part of judgment indicating whether the drug is eligible or not, what is the added clinical benefit, and that's the task of the Transparency Committee, that is one of the specialist committee of HAS. Then you have the guidance, and then the decision makers take it and take their decision on price and reimbursement. So that's our current process. So what are the areas to work? The first one is the one that Finn mentioned at the early stage of development of a drug. That's the early dialogue that I will mention. The second one is to use the HTA core model to produce the basic information we need to work on the production of our report. So that's the phase of the assessment. Again, we can share some methodological methods, so we can produce guidelines to share our methodological method for assessment. And then, as we can make requests for additional data collection, we can share the work, something we can have exchanges on this part. So basically, the part for which there is less room for cooperation is the very specific appraisal part. Otherwise, as I will show you, we have really a lot of topics on which we can cooperate. So what will be the objectives of this cooperation, according to my personal point of view? First, to avoid duplication of work. Everybody agrees on that, and Finn mentioned it already. But also to reduce the differences in the outcomes of the HTA where they are not justified. Because, for instance, do all the HTA bodies have the same data in hand? If an HTA body does not take into account a certain amount of data that is taken into account by another HTA body, maybe they will not go have the same discussion, the same conclusions, but it will just be because they do not have the same basic information in their hands. And do they use unified methodologies? Again, that's another question. So that's one of the two most important goals. The second one is important as well, is that we try not only to be passive, analyzing the data that are provided to us by the sponsors of the technologies, pharma companies or devices companies or other sponsors for other technologies, but try to interact with them to try to improve the quality and the appropriateness of the data they produce. Because, for instance, for drugs, quite often, companies know what regulators want to give the marketing authorization. There are guidelines, there is scientific advice, there is a lot of things. But once they have produced their data for the regulators and they get the marketing authorization, then they go to HTA, and HTA bodies say, okay, guys, we're happy with your data. However, we are not there to assess the benefit-risk ratio as our colleagues from the marketing authorization sector. We are there to try to inform the decision maker on the magnitude in health gain that your product will provide when used under routine clinical conditions and not in the experimental set of a clinical trial. And that's very important. So we often are not very happy with the data we have in hand, because what has been produced during the development is not adapted to answer the question that HTA bodies have to answer. So that's something we really like to, we think is important. And of course, we shall not forget that we should cooperate with regard to drugs with the European Regulatory Agency, the EMA, and we started to cooperate to improve the European public assessment reports that are produced by EMA at the time of the marketing authorization of a product. But we have now a list of topics for cooperation that you can see on these slides, and this cooperation is progressing, and it is important not to be isolated from regulators. So, how shall we avoid duplication of work and reduce unjustified differences in HTA reports? Two sets of actions. The first one is the production of the common set of data to be taken into account by local HTA, national local HTA bodies for the production of their reports. That's the core HTA information that Finn mentioned, and I'm going to see how it applies to rapid HTA. And then we have these methodological guidelines. You have on this slide a list of 9 guidelines that have been already produced, that are under public consultations, that are dealing with a methodological question for the assessment of drugs. And of course, they can be very important for everybody, for the European citizen, for the companies, for the stakeholders, for the decision makers. Let's take the example of the choice of comparators. Every HTA body is interested in assessing and has to assess in some way or another what is the added clinical benefit of a new technology. But of course, if you don't agree on the comparator, we cannot agree on the assessment of the added benefit. So the choice of comparator is one of the important points for everybody, for which we have produced a guidelines. These guidelines are under consultation on UNETA website. I will not show again a page of the UNETA website, but you have a lot of things that are currently under public consultation. So please have a look and have your say on these questions. So, rapid HTA, how can we work concretely? What is the objective? The objective is to test the capacity of national HTA bodies to collaborate to produce structure core HTA information that can be useful in the framework of the rapid HTA assessments, of the rapid HTA they have to perform. So we will produce in the next 3 years 10 pilot rapid HTA core information for drugs and 4 for non-drug technologies. And we will test also that these core information that we produce together are useful, meaning that they have been effectively used at a national level to produce an HTA report. And that's something that is, of course, important. So a lot of things have already been developed. So in the joint action that just is ending this year, and there was a background review of the national relative effectiveness assessment for pharmaceuticals that has been done by our colleagues in CVZ. CVZ is a Dutch HTA body that is associated member, a lead partner for this action. So there has been the development of a model for core HTA production that is specific to rapid HTA. The methodology guidelines I've already mentioned, the cooperation with EMA, everything is ongoing. So now, why do we need a specific model for rapid HTA? Because we have to take into consideration 2 characteristics for the rapid HTA. That is a limited time frame. The European directives say that every country is free to set up its own criteria for HTA. It's not decision-making process, but that a decision has to be taken and an assessment has to be made within 90 days, so it's a very short period of time. And the submission file is prepared by the marketing authorization holder, so that's something we have to take into consideration. So starting with the full HTA core model, the first version was developed for rapid HTA that suppressed some of the parts of the full HTA model. And now we have this first version evolved and we replaced